Hey everyone, welcome to the Commercial Carrier Corner. This is a new video series that we're doing here at Slice of Healthcare, where we're going to really focus in on the employer sponsored healthcare industry and have some great conversations. Kicking off this series, we have Andy Jackson, a consultant at Gallagher, here with us today. Andy, how's it going?
Great this afternoon. Thank you.
Excited to chat with you. Before we kind of dig in, give us that kind of 1 minute overview of your background for those that maybe aren't familiar with you, and kind of your role at Gallagher, what that looks like.
No, great. So my background is I'm a consultant with Gallagher. I was a merger partner over into Gallagher from 2011. Prior to that, I owned my own firm. I've focused solely on employee benefits and healthcare for the last 28 years. And I've specialized in self-funding for about 20 years of that. And really in the last 10 to 15 driven into what I call the weeds of healthcare and how to pull plans apart.
Andy, my first question to kind of to kick off this conversation here today is, you know, many brokers and employee benefits consultants believe that a self-funded approach can only work for specific companies, but you almost exclusively implement self-funded plans across kind of your clientele, which is 65 to 10,000 ish employees. Why are you such a strong kind of believer of these self-funded plans versus the fully funded plans?
Great question. Either way, it's a transfer of risk. So whether you're buying an insurance product to transfer the risk to an insurance company, or you're deciding to go to a partially self-funded program where you purchase reinsurance, it's about setting that risk and that tolerance, but following best practices. That's where I'm a big believer that you can follow those best practices, and I use the old saying of prepare for war but pray for peace. And when you build a plan, and what I find is that most plans have so much excess in them that in self-funding, you can remove pretty easily as much as 25 to 30% within 1 to 2 years. And that's money that stays with the employers for the long term. And in doing so, you can turn around and benefit the employees and turn benefits back into what they are called benefits. Because most employers today, when you look at their programs, they don't have a benefit. They have a punishment plan because you look at the deductibles and the out of pocket costs, and 75, 80% of our country can't afford that. And so it's a better tool to use to transfer that risk while controlling cost. And it just takes a little bit of education and work to manage a program instead of buying a product.
When you're talking with a client, what are, I guess, some of the concerns that they bring up to you, and kind of what are your response to those concerns? Because everyone, I'm sure you hear your fair deal of concerns. Maybe some warranted, some not warranted, but would love to hear kind of what you're hearing and then what your response is to those.
Great question. So yeah, one of the concerns is I typically hear is, well, we're too small to do that. Most people think that you have to be 1,000, 1,500, 2,000 employees to go into a self-insured program. Whereas I've done them as small as 35 lives. And again, financially, they're concerned about what about large claims that come through? What about preemie babies? What about these high cost drugs that are out there? And it's an education that, or I should say, an educational item that you need to address in teaching people what it is, but also what it isn't. Because when you get into that conversation and those objections, most of the time it was hearsay. They heard it from a third, fourth, or fifth party, and it was out of context, and they really didn't even know what they were talking about. So, my time in the service, we used to call them sea lawyers, people that give a lot of great advice, but they've never actually done it. And so you have to get past that and educate them.
This is a space that is probably very, very common. it seems that a lot of people will start giving advice to your point, and they're giving advice based off something they've heard and not necessarily expertise. So I'm sure you have to deal with those conversations quite a fair deal. When when you look at your experience, what would you say some of the core components of a successfully funded plan are? I know you kind of gave tidbits earlier, but kind of what is that core component like? What do they look like?
Well, the way I describe it is it's a three-legged stool. Is so number one, you have to have an administrator that has the tools and the resources to make your plan successful, and that involves great policy and procedure that is in place when they're processing and paying claims, so that they're doing all of the right things to pay claims appropriately and not overpay them. And at the same time, they're helping drive the compliance side, because you do have to follow ERISA and a little bit of compliance work there, but it's not hard once you get it under control. So that's the first major leg of the stool. The second is you have to have appropriate reinsurance contracts. And so I like to use the term appropriate, because people will tend to race to the bottom with administration and reinsurance. They want to go to the cheapest quote that they can get. Well, reinsurance, the cheapest quote is kind of like saying, I bought the cheapest homeowners I can, but I found out that hailstorm's not covered. So I can't get my roof replaced. Well, in reinsurance, you have to have appropriate contracts and appropriate pricing to make it successful long term, because that's what's going to cover your overall risk. And then funding, the same thing. You have to appropriately fund a plan so that you have an adequate amount of reserves to cover your claims cost. In that 1 to 2 bad years out of 5, there's money there for you to dip into the well, pay those claims, and move on. Because if not, you will either underfund, or again on the reinsurance, have not have your liability covered correctly. And what winds up happening is you're always behind in trying to play catch up and getting enough money into the plan. And the way that I do it with those 3 items is that I build it as solid as I can from the beginning to build those reserves up in year 1, year 2, and year 3. And then instead of chasing and doing the lowering my cost to turn around and raise my cost, my goal is to plateau cost. Keep it consistent from now on. My most successful client at the moment, we're 10 years in with no funding changes, no plan or program changes. And so we're actually adding back benefits in order to burn some of those reserves off, because we've saved so much money. But I have a lot of customers that are 4, 5, 6 years in following those guidelines, and they've not had to change their funding. And so that's unusual in today's market. When you hear about people getting 15, 20, 30% increases, these people are having large claims. The group that's 10 years in with no change, they have an individual on their plan that's taken $1 million worth of medication. But we've been able to turn that and control that cost because of those 3 items. We set that solid foundation to begin with to grow off of.
Let's stay on this, because I like the proof is in the pudding. Let's talk through some more of these examples. So let's maybe if you're willing, if you could share a specific example of a client that has been able to truly execute on this well.
Yes. So I'll share the example of that customer that's been 10 years now. I've actually worked with them for over 15 years. I had inherited them through an acquisition that we made, brought them on. And this is an employer that has 300 plus employees on their plan. Fairly dependent heavy as well. It's I would say median age in this group is late 40s. And when I first got them, they had been self-funded for a few years, but they had no money in reserve. They were using an administrator that was doing a pretty good job, but still missing a few key pieces. And part of that was the data and analytics so that we could see what was driving claims. And then their reinsurance contract was a total mess. They had too low of a specific, which is the individual deductible level that reinsurance covers. They had a lasered, 4 lasers in their contract. So they had 4 different individuals that were set at a much higher coverage level due to health conditions. And then the contract also allowed for unlimited increases at renewal. And so, but when you looked at it, the premium on that contract was really cheap. And it was like, okay, talking to them, it was cheap because they don't have to cover anything. So what we had to do is set out and say, okay, number one, we have to get your reserves built because you have no money in the bank. So we changed their funding. It was a pretty dramatic year that first year. There was a lot of intense conversations, let's put it that way. But I raised their cost 20% year one. And then we worked for the next couple of years to move their specific up to an appropriate level and looking at the data to help us set that. So it's not like the old school of spin around, close your eyes, and throw a dart at a board and say, okay, there's their spec. So we looked at it and said, based on the claims in your history, here's the risk that you can actually tolerate. So let's set your specific level there. We got that there. And then as health conditions improved and working with case management, we started negotiating to get rid of those lasers. And so we got them cleaned up. It took us about 4 years to get that cleaned up, to get those reserves built. And then what we did after that is we said, okay, we are going to meet every quarter. And every quarter, we're going to measure these metrics. And we're going to review what's driving your plan. And we're going to look at it versus your last 2, 3, and 4 years history so that we can see where we're improving, but also where you're disintegrating. Medical issues that we need to address, diabetic disease management. That was a huge factor for this group. So we poured a ton of resource into disease management for the diabetics, and not only getting them in, getting them tested, finding out why they weren't staying on top of their A1Cs, but cost of testing supplies, those types of things. And we said, okay, we need to lower the barrier for them so that they can have their testing strips and those types of items free. So we went and got a contract negotiated to get those at the lowest possible cost. And we said, okay, we're going to give them to you for free. Now we're going to go in and we brought in a group that did a diabetic cookbook and did some educational classes and teaching them what was helping drive that in their condition. And then we started looking at the next set of conditions. And then we said, okay, let's talk about wellness. And I am a fan of wellness in the sense that I think everybody needs to stay active, but I don't care if you run marathons or not. I want you to have a primary care physician. I want you to see that primary care physician every single year. And I want you to have blood work every single year. And it's just like doing the maintenance on your car. You're doing it to keep it from having a major item. And so we started catching conditions much sooner and then being able to prevent them. And then we came in about year 6 with a Centers of Excellence program. And we said, just like everywhere in the country where we're starting to drive a shortage of physicians and nurses, we said people that have high cost conditions that are very specific, we want them to go to the best care in the country the first time. And so we said, listen, if it's cancer, if it's major orthopedic, if it's major spine, if it's anything to do with your heart or transplants, we're going to give you a number that you call, because if you get a diagnosis in that area, we want you to call this number, and we are going to fly you and a family member to the Center of Excellence that's based on outcomes, quality of care, not cost, quality of care, to the best place we have in this nation. And by doing that, we're going to pay for it all. You'll have no deductible. You'll have no coinsurance. So now we're going to get you to the right place the first time. And we have had several individuals that were misdiagnosed. And it's not because they saw a bad physician. It was because that physician maybe saw one of those in their career, whereas we sent them to the people that see 10 a day. And they were able to, look at that and say, here's a better path or here's the real condition that you have. And by doing that, what we saw is we just kept lowering and lowering and lowering cost. And instead of going, okay, cost is way down, So we're going to lower rates. We built up enough reserve that we said, okay, we're going to start taking premium holidays. So we started telling the employees, guess what? Month of December, we're not taking anything out of your checks. Merry Christmas. And then we got a few years in, okay, November, December, we're not taking anything out of your checks. Merry Christmas. And then we got to the point where we're taking 3 months off because we're building so much money. And then we started looking at it and saying, okay, we can't keep taking 4, 5, 6 months. Let's start improving the benefits. So we started saying, okay, on the wellness, if you'll do these items, we're going to start waiving your deductibles and your out-of-pocket cost. So that's how we started really driving and ramping wellness participation. Is if you did not participate, you started with, say, a $2,000 deductible. But if you participated and hit all these metrics, now your deductible is either $500 or maybe even zero for the year.
That's so interesting. You flip the script because people are so scared to actually go and get particular like preventative care and things like that because they have that cost. And you're saying, let's actually create a structure that benefits you for taking those like precautions, which is going to help you prevent, hopefully major issues down the road. Man, that's a way better approach across the board because you talk to anyone, right? They're scared to spend money to improve their health.
Exactly. Well, and we've taken it a step further with not only that customer, but a few others is we said, okay, if access to care is that hard, we're going to bring the care to you. And so what we did is these groups were not large enough to have an on-site clinic by themselves. So we have now developed a near-site clinic that we took 2 or 3 different employers and put them together. And now they're a really large group for this purpose and said, we're going to give you a physician and staff that you and your dependents can access free of charge, no cost, no claims whatsoever. So now you can go get your preventative care, your primary care, your disease management, and even low-level urgent care during these hours of operation, Monday through Friday, at this facility, which is near your place of employment, and it costs you and your family nothing, ever. All you got to do is show up and use it, and it's free of charge. And what the employer has done is said, we're going to take some of that money from reserve to help fund that, because now that's a huge amount of claims that are out of the commercial system, but it's keeping our people healthy and giving them quick and immediate access to care. And we've even limited the number of patients that physician can see, because we want that physician to be able to spend 30 to 40 minutes with every patient to truly help manage their care, instead of be a 5-minute visit and then move on like they would in a normal clinic.
Andy, on these plans that have these flat premiums, what do you do from a health plan perspective per se?
Let's dig into that question a little bit deeper. Are you meaning an HSA, PPO, an RBP, or all the above?
I am curious. Like, I would say from an RBP. Let's go with the RBP.
Yep. I'm a huge RBP fan. So once I got my arms around it, what I found was I was like a lot of the other consultants and brokers throughout the country is I thought of RBP as being very disruptive in the system. And it's not if you do it the right way. And so in those plans, what we've done is we said, number one, we're going to give them a primary care network up front that allows them to access physicians with little to no issues of billing there. And then we're going to use RBP for those large claims, your imaging, your labs, your inpatient, your surgeries. And we're going to kind of segment that. But let's not assume that everybody knows how to figure that out. We're doing mandatory meetings before the plan goes effective. And we're discussing with the employees, here's how a PPO plan today works. And we're moving you over here, and here's how it works. And we're giving them examples of cost difference to them. And they pretty quickly will learn, hey, we're the first person to benefit from it. Because like on an MRI, if it was under deductible and co-insurance under my previous plan, and my plan, say, or deductible is $2,000, well, I'm probably going to have to front the majority of that. But under RBP, wait a minute, that same MRI is $280. Wait a minute, that's way cheaper for me. And so we've also had to educate them on the fact of, if there is an issue, don't dwell on it. Don't go running to HR with it. Get back to your member advocacy group. Let them know, that's part of the program. Let them know so that they can deal with it quickly. And like anything, it's an education issue. And so we realized really quickly that you got to educate the members and keep educating them. And as it turns out, they love it. I have several plans that have gone that route and will never go back.
Well, Andy, I want to thank you so much for being our first ever guest on this new series, and we look forward to future conversations. But thank you so much for joining us here today.
No, you're welcome. Thank you guys for asking me. I've enjoyed it.